Hello and welcome to Systems for Action's ResProg webinar. My name is Chris Lytle. I'm Deputy Director here at Systems for Action. We're a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. We support studies examining multi-sector collaboration across medical, social, and public health systems with the goal of improving population health and advancing health equity. So today we'll hear from an S4A project, financing and service delivery integration for illness and substance abuse is the focus of their study. And we'll hear from, if we could go back to the agenda page, thank you. So we'll hear a presentation from the team, followed by some commentary. But do know that we're saving time at the end for Q&A. So if you have questions throughout this presentation, don't hesitate. Go ahead and add those to the Q&A box at the bottom of the screen, and we'll have the research team answer those questions for you. So first, I'm gonna introduce our presenters really quickly. We'll be following up with these slides if you want to learn more about our presenters. William Riley is a professor for the science of healthcare delivery in the College of Health Solutions at Arizona State University. He's a leading authority in healthcare finance and serves as the director of the National Safety Net Advancement Center, which assists safety net organizations respond to healthcare payment reform. Our other presenter will be Matthew Moody, who serves as the director Contact Center Operations at Crisis Response Network. He oversees 100 employees in the Crisis Contact Center that fields over 25,000 calls per month with 12 years experience in the behavioral health field. Our next presenter will be giving some commentary. Detective Sabrina Taylor has been a police officer for 17 years, serving 5 of those years in Los Angeles Police Department and 12 years with the Phoenix Police Department. Excuse me. Sabrina has been a crisis intervention team certified officer for 10 years and is currently assigned to the Phoenix Police CIT squad as the coordinator. And with that, I will now hand it over to the team to present on redesigning the 911 emergency call system response for behavioral health crises. Please send any questions you have to our Q&A box at the bottom of your screen. With that, I hand it over to the presenters.
Chris, thank you very much, and good morning, everyone. I am delighted to be here with my colleagues, Matthew Moody and Detective Sabrina Taylor, and I will be presenting this today, and we'll be interchangeably going back and forth to discuss these items with you. I'm Bill Riley, and again, it's a pleasure to review with you the set of projects that our team has been working on with over a number of years. So the central pillar of the way we view the multi-sector systems of alignment is that if we want to improve the health of the population, then we need to go outside of the healthcare delivery system. Because inside the healthcare delivery system, we're not doing a very good job at achieving that goal. We do a really good job at achieving other goals, but not improving the health of the population. So our team for about 5 years now has gone outside the boundaries of public health and healthcare to community organizations. And for several years, we have worked with approximately 50 community organizations, including the fire department, the police department, the crisis response network that Matthew is going to describe, and so forth. And so we've worked with a lot of shareholders and stakeholders, and together they helped us really understand the importance of care fragmentation for individuals with behavioral health disorders. And the multi-sector lack of alignment for serving persons with behavioral health disorders is truly a striking example of what the multi-sector systems alignment is all about, because there's overlapping financing mechanisms in terms of how treatment for these individuals is paid for and coordinated. There are conflicting policies between the different sectors in terms of how these persons are treated, and primary, secondary, and tertiary prevention. And there's clearly an institutional bias in our healthcare system for persons with behavioral health disorders. So we selected this for several different interventions because individuals with behavioral health disorders in this country truly do characterize profound inequity, significant fragmentation, wasteful duplications, and a severe lack of coordination. So it's been a privilege and an honor for us to work with our partners to identify through their leadership what ways that more research bases and evidence can be developed in terms of how to coordinate care better for these persons outside of the healthcare delivery system. Next slide, please. So the purpose of our study that we're going to be explaining today and presenting today is a co-location of behavioral health specialists in the 911 emergency dispatch center in Phoenix, which is the 5th largest city in the country. And the whole purpose of this, and Detective Taylor will touch on this to a great extent, is law enforcement involvement is really important for persons experiencing a behavioral health crisis when there's a threat to individual safety or other safety. So certainly law enforcement needs to be involved then. But the bulk of the behavioral health calls and interactions that law enforcement has with behavioral health is not threatening to self or others. So the goal of this study is to align the community resources with the rest of the other sectors to divert persons from entering the justice system and starting with law enforcement, and then to better serve them when they're experiencing a behavioral health crisis. So it's really a twofold aim, which is first of all diversion, and coincidentally is that diversion can result in better care for those persons. And the police department will be the first to tell you that they're not the persons who are best trained to serve, to be involved with behavioral health crises, unless of course that there's a danger to people. Next slide, please. So to summarize that background, the reliance upon the law enforcement to respond to individuals experiencing a behavioral health crisis, in our view and in the view of law enforcement, does represent a fundamental systems misalignment in many, if not most, communities. And one part of that misalignment, and Detective Taylor will talk about this, is in the 911 emergency dispatch system, which is where it can be a launch pad for how law enforcement does get involved, because both law enforcement and as we've worked with our other partners in the Phoenix Fire Department, those two organizations are the first point of contact for many persons who are experiencing behavioral health crisis and their families. But both the fire department and the police department know that a preponderance of those calls to the 911 emergency dispatch center for behavioral health crisis really don't require law enforcement or the police, the fire department. And typically, and here in Phoenix, for example, that's the only option available for the 911 dispatchers. Next slide, please. So in conjunction with Glenn Mays, we've developed this framework for a multi-sector system alignment. And so it's got 4 components to it. Carrington, if you could. Yeah, so first of all, we define, I'll just go through this quickly. We define an alignment problem as where an area where there's a persistent gap in services between sectors, typified, as mentioned before, by conflicting funding mechanisms, siloed reporting requirements between the different sectors, and disconnected information systems. So the alignment mechanisms in this model are the methods and techniques to engage the stakeholders. So we developed this model as a result of working with our stakeholders over a number of years, because they are the ones that that identify the alignment mechanism. So how to engage stakeholders in a way to identify and analyze the alignment problem, as well as developing a consensus on a solution. And then the solution is that multi-sector consensus, which again, our presenters today are going to show a tremendous example of how there's a multi-sector consensus and cooperation to implement an intervention. And then finally, all of that is aimed toward resolving the alignment problem and an improved population health status. So next slide, please. So our, excuse me, our hypothesis is that co-locating a behavioral health specialist in the emergency dispatch center, in the 911 center, will increase the diversion of the police who are dispatched for a behavioral health crisis. Again, there are times when it's absolutely essential for the police to be involved. And the real challenge that Matthew is going to, and Sabrina will be talking about, is how to differentiate between when police involvement is necessary and when it is not. And so the results that we expect, ultimately the outcomes, are reducing the incarceration rate related to the 911 dispatch center calls for persons who are experiencing behavioral health crises. Next slide, please. So this is a longitudinal analysis, and we have a comparison group, and we are applying that framework that was shown previously. And as I mentioned, the study setting is the 911 dispatch center in Phoenix, which processes over 2 million calls annually. Next slide, please. And I'll start with the results, and then we'll explain how those results were derived. So as a result of the program that was created by Detective Taylor and led by Matthew Moody, so having a behavioral health specialist in the 911 dispatch center resulted in over a 300% increase in calls designated as behavioral health crises. In other words, the dispatchers identified calls more as behavioral health related, and that was the beginning of the diversion, that if the call is identified as a behavioral health call, is it possible to direct those calls toward behavioral health resolution rather than a law enforcement resolution? Matthew, is this would you like to comment on that very important point? And Matthew, if you could also just introduce the Crisis Response Network in terms of the organization, what your organization does and how you've been instrumental in this project.
Yeah, absolutely. I think starting off with how the crisis system in Arizona works is really helpful. It's provided through Medicaid, and it's pretty robust. So you have 3 levels. You have a mental health crisis line, and that's, Crisis Response Network. As we talked about earlier, you can handle up to 25,000 calls per month. And we're able to handle everything from someone feeling lonely all the way up to someone who's acutely suicidal, and everything in between. Substance use, we can help with domestic violence, anxiety, depression, psychosis. So we can handle a wide range of things. The crisis system also includes mobile crisis teams. So that's 2 crisis specialists that will go out and meet somebody in public wherever they're at, and a long time with them and try to help find a resolution and can transport to a facility. And there's also 24/7 crisis facilities available where you can see, a nurse practitioner, psychiatrist, and mental health professionals. So that it's kind of a hospital setting, but also kind of a drop-in center for mental health. All of this is available to the public free of charge. There's no limitations or qualifications you have to meet to get these services. So it can be someone who's homeless, it can be someone who has private insurance, it could be someone who's a multimillionaire. So it spans the whole gap over all populations. And at the crisis line, we're able to resolve about 70% of our calls over the phone. And so the beauty of this system is if 911 diverts a call to us, we're going to be able to handle that, and it's a separate system from the police. And I think that's the real power in this setup is when we divert a call, the police are not handling anymore. So that frees up the police to do police work, and it also gets the person over to a specialist. All other specialists in the system typically have multiple years in the mental health, behavioral health system, how to handle crises, and typically have a bachelor's degree. So it's just a much higher level of training that you're going to get than a 911 operator whose mental health experience is a lot, on the phone, on the job experience, and a little bit of training that we've done in this coordination. And then you have officers who are specially trained, but that's an additional training on top of what an officer normally gets. So they're just not going to have that clinical experience that one of the mental health specialists is going to have. I think that covered everything, right, Bill?
Yes, great. Thank you very much, Matthew. That's perfect background for the next slide then. So next slide, please. So those are the results. And again, this is the distribution of calls to the emergency 911 center. The central column, please, at the bottom, Carrington. So the call center gets about 2.4 million calls a year. And you can see the distribution, about 91% of those calls, 2.1 million of the calls are for the police department, and about 215,000 of the calls are for the fire department. Next slide, please. And this is a run chart showing the performance of the calls involving Matthew and the crisis response network. And from starting on the left, from January through January of 2019, you can see that calls involving the crisis response network were around, the median is about 190 per day. We'll show that in a moment, per month, excuse me. And Matthew started the training in February. And even before Matthew co-located, the training itself had a positive impact on the use of the crisis response network. And so from February of 2020, when the training started, all the way through the co-location of Matthew, which was a challenge in itself with respect to COVID that Matthew will describe, and in terms of some of the improvising that Sabrina and Matthew did. Despite that, you can see that there was a tremendous improvement. So this is what we call this is a process shift, and those two plots before and after Matthew's intervention are described as special cause variation. In other words, these are signals, not noise. So on the basis of those observations of special cause, we replotted the same data. Next slide, please. And what these are the same data that you saw a moment ago. However, the process shift, we recalculated the medians, and I'm having just a little glitch myself here. So the overall median on the previous slide was about 329 calls monthly to the CRN. And then after the process shift, which you see on this slide now, the median for before the intervention was 251 calls, and the median after is 589 calls per month. So basically that's about 130% increase in the number of calls involving CRN. And by involving CRN, that means that the dispatchers make a decision that it could be a behavioral health call rather than a law enforcement call. Matthew, any comments to elaborate on that point?
No, I think you got it well. I think it's important to comment on how COVID impacted this. So February and March, we did training for the supervisors, and then I actually started co-locating right there in March. So you can see that huge spike there up to 900 in March. And then shortly after, that's when COVID hit. So when those numbers go down there until October, you can see there is still a strong positive impact, but I got back into the dispatcher in October and November into the center. So you can see those numbers go back up again.
Great, thank you. And again, even though COVID prevented Matthew from being physically present, there was still a halo effect just in terms of the efforts by the supervisors and Detective Taylor, and knowing that that CRN was available to assist them. Next slide, please. So the real important question for this is, why is it important to have behavioral health co-location in a 911 dispatch center? So with that, if I could introduce Detective Sabrina Taylor. And Sabrina, if you could give just an overview of the programs that you have started to help address behavioral health for our citizens, and then also specifically in terms of why behavioral health co-location is important in the 911 dispatch center.
Sure, thanks, Bill. So back, at the beginning of our charts back 2018, 2019, the National Police Foundation did a study at the Phoenix Police Department because of a inordinately high number of officer-involved shootings. And they came back with 9 recommendations. And recommendation number 9 said that we need to do better with behavioral health. And that was a little bit challenging for us because we had the systems in place that are nationally recognized as best practices. We had been training officers and dispatchers on, how to use these systems and what they can do since 2001. So what were we not doing? And even though we had the systems and we had told, people that they could use them, they really weren't utilizing the system to its full potential. And so we had to figure out, what do we have to do different? The challenge with our communications, our 911 dispatchers and communication operators, was that they just don't have a whole lot of time for training. They're chronically understaffed. They're working mandatory overtime shifts, and you can't just take them out for a day of training. So we were able to work very closely with their command staff to implement a couple of online videos. And then we were able to get 2 hours of in-person classroom time with them, where Matthew and one of the dispatch supervisors went over with them, what the crisis system can do for them, how to use it, and encourage their use of it. And we also got permission to track it. So that's why, if you go back to like January 2019, there's a big 0 because we didn't have any method of tracking this before. And then you kind of see the small increase and the big increase in March, which is when we rolled out the training. And so then you see that sort of first kind of steady line of, this is them right after we've kind of re-explained how to use it. But we were fortunate enough to have some funding to try to co-locate somebody with them. And because we're trying to completely change a culture and completely sort of shift what they had been doing for years and years and years, we knew it was going to take more than just explaining it once. And we thought that it could be important for somebody to be there in real time to answer questions and to sort of help them push the envelope of what this could do. And I think it was amazing that the data so correlated so well to the actions that we took.
Great. Thank you, Sabrina, very much. Is there anything else about the culture shift that you'd like to comment on, or do you feel that was covered?
No, I mean, I think that was covered. the training that we rolled out to all our dispatchers in the very beginning, it's now embedded in new employee training. But, as we all know, you get your new employee training, then you go out for your on-the-job training, and the person who trains you is the person that's going to really impact you and mold you. And so if we could, even if we could have somebody co-located with them for a short period of time, that sort of helps the current staff really embrace this as an option, then they will mold the new employees that come after them. So in order for this to stick and stick quickly, we had to change minds of people who have been there for a while.
Great, thank you, Sabrina.
Sure.
Next slide, please. And so this is the real important aspect of the intervention and the how to achieve that, the results, and moving more toward that multi-sector alignment that Sabrina just mentioned. So Matthew, could you please elaborate on these three questions? So what did you do? How do you do it? What were the barriers as you introduced the co-location? And then most important of all, what are the successes?
Sure. So my day-to-day when I'm in the dispatch center is I have a station. Basically, I'm sitting at a station that's the same type of station as the 911 call takers, dispatchers. And I'm integrated into their computer systems. So the computer system they use to dispatch is called a CAD system, CAD. And it's how they document what happens on a call. It's how they use an instant messenger back and forth. And it's also how they communicate to the police officers what's going on. So it's really central to everything that they do. And initially when I started, I was sitting in the room with them, and I would have discussions with them and wait for them to have questions. But we decided that getting into these computer systems and integrating with them was going to be helpful because I can communicate with them in the way that they're already communicating. A lot of what I do is also kind of relationship building. So being physically there, but also if they have a question, going up to them in person and talking to them about it, joking around with them, building those relationships and answering any kind of questions they have. The longer I'm there, the more questions get asked and the more kind of integration between the systems we see. I think one of the things I was surprised from coming from a clinical background is I initially thought that they might have a problem assessing if there is a mental health condition there. I've been surprised that they're really good at identifying that. I think the big problem is they're used to using, Sabrina always says it, they have one tool, which is sending an officer out. And if you have a hammer to solve a problem and no other tools, especially one that could be solved better by a screwdriver, you're still going to use the hammer every time. There was a liability concern. A lot of the dispatchers were concerned that they would transfer a call to the crisis line and that person actually did need an officer to respond in an emergency capacity, and that person would get help or would get police, but not necessarily mental health. Or if they needed a police officer and there was immediate danger and they didn't send one, that person could get help. That's what I was trying to say. So we had to do some kind of training and explanation about what the crisis line's risk assessment is. We do a pretty in-depth risk assessment. A lot of times it's actually more in-depth than what the police are going to do to make sure that they're safe. And so helping them understand, we are going to send the call back to them if they transfer us something and they are in immediate danger, or during the call, immediate danger comes up. So that's been really helpful. And I think the big thing we're looking at next is kind of how they sell what the crisis line can do. A lot of people are calling 911 knowing or wanting an officer, wanting some kind of legal outcome, and trying to explain like, oh, hey, there's this mental health crisis line. They're like, this is not a mental health issue, even though we can we can hear it over the phone, like there's a mental health component to this, and having a crisis team come out is going to be better for you than an officer. You know, having a social worker coming out and helping with social work problems is going to be more effective. So what we're working on is getting them to kind of sell it better, and maybe not say it's a mental health crisis line, just saying there are specialists that could help you with that. I have to transfer you over there. Would you like to speak with them, or something along those lines? We're still trying to figure that out. But overall, you've seen the numbers from the previous graphs. It's been a really big success. It's exciting, and you know, I really want to continue this partnership and then do it with other cities too. So hopefully, this model is going to help everyone understand how to handle mental health better.
Great, Matthew, thank you very much. So Matthew, you touched on this. So what in your mind is the biggest success to date?
Well, I think just the dispatchers understanding the crisis system better, and just the kind of closeness. There's a big respect between the crisis specialists and the 911 crews. They understand and trust each other now. More than they did, instead of just, we're sending this call and we don't know what's happening to it. There's that like kind of collaboration, and it even happens on the phone calls when there's going to be a handoff. They're just better collaborators with each other, and for me, that's the biggest success is that integration and trust between the systems. And I think that plays out in the numbers.
Yeah, and you know, and that's real consistent with Sabrina's comment about that culture shift. And of course, we all know that changing cultures takes time. So thank you. Matthew, anything else at this point?
No, I'm interested to see what kind of questions people have in the Q&A section, but.
Okay, well, I am too.
Yeah.
Next slide, please. So you saw that the number of calls involving the CRN and behavioral health increased dramatically, and that's despite the COVID-19 that happened coincidentally with Matthew's interventions. Equally important, and in some respects even more important, there was a 20% decrease in the dispatch of a police officer for behavioral health crises. So let's look at that and talk about it. So next slide, please. This shows the number of police officer dispatches, again, pre-intervention and post-intervention. So overall, there was the overall performance of the process, sorry, I'm having a problem again, was about 210 diversions per month, which meant that the police officers did not need to be, the police officers were not dispatched because a decision was made that they did not need to be involved. And prior to Matthew's intervention, again, you can see on this control chart that there are two incidences of special cause. So before the intervention, which is a vertical line in February, all of those plot points below the median indicate special cause. And then after the intervention, all of the plot points are above the median, which is another incidence of special cause. And so based on that, we could conclude that there was a process shift, which was that signal. And next slide, please. And when we reanalyze the same data with different medians, that process shift prior to the intervention, there were 137 diversions per month. And after the intervention, there were 365 diversions per month. So both of those processes, pre and post intervention, are stable, but you can see that as a result of the intervention, there was a significant shift. It was P less than 0.001 as far as the probability of these types of plot points. So, so it's clear that the number of diversions did improve, and it had a number of really important impacts that we're going to be talking about for the rest of the presentation. So how about Sabrina, before I continue, do you have any comments about that, please? and the impact that diversion has for the police department and for the citizens?
Yeah. So I think it's super helpful that we're sending these calls over to crisis specialists who can do a much more appropriate intervention. And so imagine if this person's crisis is being handled in the least restrictive method possible, solely over the phone. Nobody's coming out to their house. No mysterious vans are parked in their parking lot. Nobody needs to know that this person had a bad day. Contrast that with, maybe a slightly more intrusive intervention. You send a mobile team to the most intrusive intervention, which is you send the police department. And, dispatchers only have generally, like we said, one, maybe two tools, police or fire. Police departments only have a handful of tools. I arrest you or I move you voluntarily. But either way, I'm going to take you out of the most comfortable and supportive environment and stick you somewhere in, a hospital, a jail cell. Not all the choices may be therapeutic, and our hands are sort of tied. Officers also are responsible to the larger community. My goal is not so much to make sure that this individual patient gets the help that they need, but that the community at large gets the help it needs. So if this patient is no longer causing a disturbance in the neighborhood, then I have done my job to the best of my ability. Whereas a clinician and the system that we're diverting this person into, that person is their primary responsibility, and that person's health outcomes are their primary responsibility. And so they just have, by definition, a much better focus. So the more that we're able to divert people into the appropriate services, the better their health outcomes are going to be.
Great, thank you very much, Sabrina. And then the last result that we will show you is an interesting development, and we're not sure how to interpret it, but the next slide, please. So you saw that as a result of Matthew's expertise in the 911 dispatch center, that the reliance on behavioral health specialists rather than the police went up substantially, number one. Secondly, that the diversion of the police away from these calls also improved. In other words, the police were diverted. What this run chart shows, and Kaylee did a circle around the special cause there. So in the middle of this intervention, this 24-month period that you've been looking at, what this shows is the ratio of diversions to the overall calls. So the median is 64%, which means that basically 64% of all of the calls that involve Matthew and behavioral health and his organization resulted in a diversion. And so that's even though that the number of calls went up. So what we're going to do next is look at that, do a root cause analysis on that incident where the diversions rate actually went down. So again, what this is showing is the proportion of calls that were not dispatched as the number of calls not dispatched as a proportion of the total calls that involved CRN. So we're not exactly sure how to interpret it, except that we have concluded that it's a very positive impact. So one of our interpretations is that if the proportion of diversions is staying the same, what that means is the more calls that get sent to CRN, then the more diversions that will occur on a constant rate. Matthew, do you have any comments or additional information to add to that interpretation?
No, this is something that I need to think about. So I think collaboration between us is going to be good. I haven't sorted through this mentally to have any comment on it.
Okay, great. And we're still scratching our heads too, but we know it's important, but we thought that you'd be interested, and maybe there are some experts in the audience that might have some comments and observations on that also. So next slide, please. All right, so just to summarize, a substantial portion of the 2.5 million calls to the 911 every year in Phoenix for the police department are behavioral health related. And there's a strong stakeholder consensus among all of the important organizations that help serve persons with behavioral health disorders that the current multi-sector system is poorly aligned. Next slide, please. And as a result of this intervention, what we are able to preliminarily conclude is that behavioral health co-location in a 911 dispatch center significantly increases the use of behavioral health expertise. So as you saw before, by about 135%, from 251 per month to 589 per month. And again, a really important caveat, that was in the COVID period. So all things equal, had Matthew been able to be in the center, we're confident that that number would be even much, much larger. Next bullet, that behavioral health co-location in 911 dispatch center also significantly decreases the police officer involvement by 166%. And then the last bullet is that the use of the crisis response network, that's the organization that Matthew described, has improved dramatically both the rate of diversions for calls involving the CRN and has remained stable. That's that last result you saw. Next slide, please. And some more conclusions. So the co-location of a behavioral health specialist in the 911 dispatch center does increase the recognition of behavioral health crisis among the dispatchers. So that's part of that culture shift that Sabrina mentioned too, is just that recognition. And then also having an alternative available for them. And so as the use of law enforcement for behavioral health crisis declines, we're hypothesizing that the likelihood of incarceration is also going to be reduced. And I'll talk about that in a moment as far as next steps. So these findings are not new, but the evidence base in terms of the impact of behavioral health co-location is very limited. So this study is contributing to that limited evidence base, and we're going to be digging further and analyzing the determinants of the impact to contribute even further to the evidence base on multi-sector alignment. So with that, after Sabrina makes her response, we'll talk about next steps. Next slide, please. And you've already heard from Detective Taylor, but I'm delighted to introduce Detective Sabrina Taylor. And Sabrina, if you could take it from here, please.
Absolutely. Thanks, Bill. We are just so happy to be partnering with ASU and to have a partner to look into the data and do some real statistical analysis on it so that, it's not just, well, we feel this went better. We know what works. We have specific points, and it's been, very helpful. And, there's been a lot of focus on the police department, especially when you're talking about culture shift, but it was a culture shift for the crisis call takers too, because we had never, even though we had told people you could use them in this way, we'd never actually used them in this way to a significant amount before. So, in part of the training and introducing this concept, our dispatchers actually went and shadowed crisis specialists, and we made that available for crisis specialists as well, so that we could really get to know each other. And I think, you heard in Matthew's comments that it went very well. We were able to accomplish a lot. And so if you'll go to the next slide, please. Part of the conversations nationally has been about the sequential intercept model. And here in Maricopa County, we are blessed to have robust help in Intercept Zero. We have crisis lines, we have crisis mobile teams, we have great Medicaid services for people with mental illness to prevent them from entering crisis or entering a crisis that's going to involve law enforcement. But, 911 is a very popular number. It's a number people call, Matthew has explained some of the things he's overheard. People use it like Google. And so that's the number that they're going to call. They may not know the crisis line number. Hopefully that'll change with 988, but that's a few years off. So basically what we're doing is punting the ball from Intercept 1 to Intercept 0 at the earliest possible moment. And we're giving 911 the power to, punt the ball back into Intercept 0. And if it's still appropriate. And now, we have a bunch of other options. If 911 does have to send law enforcement, if they are working with the crisis line, a mobile team will co-respond too. So you have co-response basically not only at the dispatch level, because you have Matthew embedded with us, but you have co-response at the law enforcement level, and that the crisis line is sending a mobile team, 911 is sending officers, and you have officers and clinicians responding at the same time. And as soon as it's safe, the mobile teams will take over from the officers. So you have a lot of back and forth between Intercept 1 and Intercept 0, and a lot of ways to get the right services to the person when they need them.
Great. Thank you, Sabrina. Should we go to the Q&A and the comments? Chris, do you want me to handle this, or do you want to do it?
Sure, I can read them off.
Okay, thank you.
And any of you or all three of you can respond to them in turn if you like. So we've got about 14 minutes left, but if folks still want to add questions, feel free to do so. So the first question, let's see. Bill, I'll direct this to you. What impact on your integrated system is expected when the new federally mandated national 988 lifeline number is implemented by states in the summer of 2022?
I can take that one. So the 988 number is going to be great. It's going to give, like Sabrina said, an alternative to 911. I think that once that goes live, we're going to have a lot more crisis calls in general. And hopefully once people get used to using it and know the number, that it's going to kind of divert itself. 911 has been around since the 80s. And so people know that number really well. Like if I have an emergency, I call 911. So I still think we're going to need this integration throughout this. And I think there's going to be people that, again, don't know that they need 988 versus 911. They're not going to understand that it's something that a crisis line can handle, if that makes sense. So we're still going to need this integration between both systems, in my opinion.
Okay, thanks, Matthew. So could you envision this model being applied to responding overdose responses in cases where patients are successfully resuscitated but refuse transport to ER? And if so, do you envision any obstacles?
And Sabrina can help talk to this too, but I think that in some situations, a mobile crisis team can help. I think getting them connected with, a detox facility or something would be helpful. That isn't something that we've attempted yet. I'm not familiar with a lot of times where police or fire have called us and said this happened. But I think anytime that you can get follow-up services for someone in that situation and let them know that services are available, that's a powerful intervention.
Yeah, so this is kind of like that co-response model. So, the the ideal vision being that anytime police or fire respond to a call of a behavioral health nature, that a mobile team responds with them. And, you know, that is, that's a completely separate study, even though they're like kind of interrelated, because what we're doing there is we have offered, I mean, we have those systems in place that can absolutely happen. We have plenty of mobile teams to do that. And we have told police and fire since 2001 that they can do that. But again, there's something that's stopping them from doing that. Maybe they don't totally understand what crisis could do. They don't totally understand, you know, what happens in family dynamics after they leave, because we're so focused on, I just saved your life and now it's happy ever after. And, you know, within, you know, police and fire culture, there's that inability to see the long-term impacts because we just don't see it in our professional careers. We go on to the next call and to the next call and the next call, and nobody calls us back and says, hey, by the way, that thing you said was the instigator for this person going into recovery and living a long life. And often, sometimes that's 4, 5, 6, 7 years down the road, and the person doesn't even remember the name of the officer that helped them, although they do remember the contact. So what we would have to do there is the same thing we're doing here in dispatch, but out with police and fire. And we are working on that. It'll be a little bit slower. There's a lot more of them. But as of right now, police and fire do have the ability to call for a mobile team. And because of the work that we're doing in 911, even without intensive work yet in with police and fire or like a slow start, the dispatchers are sort of already changing the narrative because they're sending mobile teams to more things. They're offering mobile teams a little bit more. And you see a slow expansion of the minds of officers and firemen to think, oh, I could probably use a mobile team here. So I think that's version 2.0. But they're so well blended, and we already see sort of bleed over in that direction.
Thank you, Matthew and Sabrina. And Bill, were you about to chime in?
No, go ahead.
Okay. So we received a couple questions concerning racial equity. So I'll sum it up this way. Given the racial inequities present in the prison system, does the crisis line or this program have any data about the race or ethnicity of those helped by this new method? Or was there a racial equity lens to this?
Matthew and Sabrina, if you could please chime in on this, but that is a really important question, and it's an excellent question. The first answer is no, we have not done any analysis on that yet. I don't know if we can, because I don't know if we collect any data that would help us widen that lens. But Matthew and Sabrina, do you have any thoughts?
Go ahead, Matthew. No, I was going to toss it to you.
Okay. You know, on the crisis line, people have to self-identify their race. So we're not documenting their race in general unless they self-identify. Or if we're going out and sending a mobile team out, then we will, you know, ask that information. I think this is definitely, like Bill said, someplace that research could be done. But yeah, I think so. I guess the way that we kind of think about it as, you know, the minority here is people with mental health issues. But there are definitely disparities between how mental health is assessed between races. So that's definitely an area that the system can work on and should work on.
Great. Thanks, Matthew.
Okay. And how would you imagine the system, how would you imagine the system working in rural settings, and where might it break down?
Yeah, we've actually replicated this. We don't do co-location in rural areas, but in Arizona, there's a smaller city called Flagstaff, which is where Northern Arizona University is. And then we've done a couple smaller areas in Arizona. So we are working with this. In those rural areas, the police end up doing a lot more what I'll call social work, because they're not having to they're dealing with like a wider range of things. I don't know if Sabrina can explain this better than I can, but they end up having to do the social work aspect of things. So what we're running into is the 911 centers are like, we can already handle this. We handle this in house. So that's something that we've been working with. But the system can work and does work in those systems if you have, the crisis system that we have set up, which is crisis line, brick and mortar facilities, and mobile teams that go out. It's just a better recognition of those services being available, because Phoenix PD has been working on it for 30 years and working with the crisis system for 30 years. So you have that culture shift that we were talking about. Did I miss anything, Sabrina?
No, and that's, since law enforcement and dispatchers have done this for so long on their own, you do have that barrier of, well, I can handle this. And so it just takes a few minutes to explain, yes, you can handle this temporarily. And you can make this go away for now, but it's going to come back tomorrow and tomorrow and tomorrow and tomorrow, where you could hand this off to a social worker who can hold this person's hand and walk with them through the long process of recovery, and you could fix this for good. And so it's getting them comfortable with sort of handing things over. And, as a law enforcement officer for almost 20 years, I'm a control freak. I want to do it myself. And it's very, very difficult for me, to hand it over to somebody else when I think I could just handle this myself and then I'll know it gets done right. And so you have to build that up, and you have to make the handoff smooth. Having, the crisis line cover, the central and northern parts of our state, just having one number and having it as easily accessible as a toll-free phone number that your phone can call without minutes, makes at least that handoff part super easy.
Thank you. And I think we have time for one final question, if that's okay with the presenters. Could you speak to the clinical expertise? And this was directed to Matthew specifically, but I'll open it up to everyone. Can you speak to the clinical expertise you applied in this work, and the other types of clinicians who may be able to fill this sort of role in replication sites? This person is thinking about task shifting and cost control opportunities specifically.
Sure. And this is a really good question. I think when you look at what other police departments across the country are doing, is they are hiring a social worker or counselor that has clinical knowledge and helps identify mental health calls. Whereas what we're doing is doing that, as well as we have this other external crisis system. So I think the benefit of what we're doing is having that other system and then bridging the gap between the systems, instead of trying to add someone into the dispatch center that is going to improve the clinical care in the dispatch center. You can see from the training that we did that there was a bump in how many calls got diverted. I think that would also happen with the dispatchers identifying someone with mental health issues better. And so even right now, what the dispatchers at Phoenix 911 do is they'll put in there, this is a possible mental health situation. Even if they do have to dispatch an officer, they'll still put that in the note. And that lets them, officer going out like, hey, there might be a mental health condition going on here. So I think that having a clinician in the dispatch center is going to be helpful in general. And then clinical expertise. Yeah, there's just a lot of, when we talk about the clinical expertise, knowing what it sounds like when someone has potential schizophrenia symptoms, or knowing what it sounds like when, someone's having issues with their family. It's a presenting issue of, I'm getting kicked out of my house, but listening a little bit and seeing like, well, from my experience on the crisis line, it sounds like there's a conflict there, and an untreated mental health condition might be the core of that. And so then we can kind of like do that kind of thing I was talking about earlier, like selling it better and saying, well, it sounds like you're having trouble with your family. There's a place that can help with that. They might be able to help you find more housing or help you resolve the problem. I think some of those things that I've been able to kind of pick out, and I think a mental health specialist can pick those things out and kind of guide the 911 operators a little bit on that. That's definitely helpful because the 911 operators have heard a lot of stuff, but they're not focused on the pattern of just mental health like a crisis clinician would.
Thank you for the response, Matthew. Got a little overly ambitious with the Q&A, so we're almost at time. So I do want to make sure I thank our presenters today on the timely findings of their studies. If you have any additional questions, feel free to reach out to us. We'll be following up with an email, the link to this presentation and also to the slides as well. Quick announcement before we go: if you want a certificate of completion for today's webinar, there's a survey at the end of the session. Fill that out. We'll also email you one. And exactly, so we have a new funding opportunity. Check out our funding opportunity page, systemsforaction.org. We are looking for proposals to measure solutions to the wrong pocket problem. If you want to learn more about this opportunity, check out our funding opportunities. This funding opportunity is open until June the 9th. Feel free to learn more about this opportunity on our webpage. And with that, thank you so much for attending. We hope we see you in our upcoming webinar, April 7th, same time, same place. You'll be hearing from our team on the effectiveness of homelessness service networks and coordinating services during COVID-19. Thank you, everybody, for your great questions and for your attention. And we look forward to seeing you April 7th. And thank you for the ASU's presentation.
Great. Thanks. Thanks, Chris.
Thanks, everyone.
Thank you.